up to this point the out of hospital management. So what we're going to look at now is things that you overly won't have control of in the pre-hospital setting, but what is a definitive treatment and what it looks like for your patient. So kicking off into the next part, we look at angioplasties is a procedure to open narrow or blocked blood vessels that supply blood to the heart. These blood vessels are called your coronary arteries, as discussed earlier. The one imaged here is the LAD, and the LAD is what we would otherwise call our widowmaker. A coronary artery stent is a small metal mesh tube that expands the inside of a coronary artery. A stent, which is what we would normally hear it referred to as, is often placed during or immediately after angioplasty, and it helps prevent the artery from closing up again. A drug-eluting stent or drug-eluting stent has medicine embedded in it that enables or prevents the artery from closing in the long term. So this is our definitive treatment. This is our mainstay goal that we may need to do for our patient post-arrival. So we get there, they're in a well-established infarction state. We give them some immediate interventions, but it's just not enough to stabilize the patient long-term. If this occlusion has occurred, there has to be something causing it, and if that is the case, then it may reoccur. So getting them to the hospital, having an effective handover and providing that underpinning information will allow us to ensure that they get the right definitive care. So if you look at a thrombolytic that is being provided, and this can be provided more and more in the pre-hospital setting, so it does still require an intensive care paramedic for state ambulance services, but it is becoming a more prevalent treatment that can be administered in the pre-hospital setting. Generally, this was reserved for hospital treatment, but this is your to removing the thrombi that has occluded the artery. And as you can see here, distal to that thrombus location, there is no circulation, and this is where we start to see infarction of the myocardium. Post thrombolytics, and with successful application, you can see that the artery perfusion and circulation is reestablished. So it's clear as day when we look at it in this context of just how important reestablishing distal perfusion is to where an occlusion occurred. Heart failure is the term used to describe the state when the heart is no longer able to maintain its function. That is, to maintain an adequate cardiac output, which we know includes stroke volume, as well as our heart rate, to pump blood adequately or be able to do so only because it is under so much strain that it is causing itself damage. In other words, the heart is weakened and the pumping action is impaired, causing heart failure. The heart does not completely fail or stop functioning as it does in cardiac arrest, but instead functions less effectively. So we may pump a significantly reduced volume of blood around the body. Heart failure can come on quickly because of some major events like a heart attack, causing widespread ischemia, resulting in a dysfunction to the conduction system or other areas. Or more slowly, depending on what the underlying cause is. And in these slow cases, the heart often adapts to working harder and compensates quite well for a while, but eventually cannot cope and people start to have symptoms. We can sort of relate this to atrophy of the heart, where it becomes significantly enlarged, and at the same time that occurs, the ventricle size is significantly reduced. Chronic heart failure tends to affect elderly people and occurs in about 1% of people aged between 50 and 59, but becomes more common in the age group of 80 to 89, where occurrence rate is greater than 50%. In Australia, nearly 1 in every 100 admissions to a hospital is because of chronic heart failure, but it also accounts for 2% of all total deaths recorded in the statistics. It's estimated that the US, almost 5 million people have had heart failure. Over 600,000 develop new heart failure each year. And that is because as we get older, our bits and pieces tend not to function or work as well as what they used to, thus leading to a dysfunction. Common causes of chronic heart failure is ischemic heart disease, where the heart is not getting enough oxygen, and those distal points to whichever artery is occluded becomes ischemic, thus dysfunctioning the ability of the heart, resulting in necrosis and death. previous heart attacks and concurrent heart attacks that affect multiple arteries. Essential hypertension makes it harder for the heart to get blood and make coronary artery disease worse by causing hardening of the artery walls or collapses in some cases. Diabetes doubles the risk of developing chronic heart failure in men and increased risk 5 times for women. Less common causes could be dilated cardiomyopathy, a condition where the heart just gets bigger and wider without a known cause, and valvular heart disease, early aortic stenosis, where blood has trouble getting past one of the major valves in the heart. So it might be that the valve doesn't open properly, it's creaked shut a little bit, or it's just not functioning as it should. Heart failure develops when the heart, by an abnormality of cardiac function, whether you can detect it on an ECG or not, fails to pump blood at a commensurate rate with the requirement of the metabolizing tissue, or is able to do so with an elevated diastolic filling pressure. Left-sided heart failure is our worst heart failure. There are 2 types of left-sided heart failure. Drug treatments are different for each type of left-sided heart failure. When we look at the first one, heart failure with reduced ejection fraction, also called systolic failure, i.e. meaning that the amount of blood being ejected is insufficient. The left ventricle loses its ability to contract normally. The heart can't pump with enough force to push enough blood into circulation. So as that surface cells become ischemic, we may see that instead of a nice, powerful contraction, we might get a drastically reduced one. And of that 70 ml of blood, we may see only 20 ml be effectively ejected from the ventricles with each cycle. Heart failure with preserved ejection fraction, which is also called your diastolic failure or diastolic dysfunction. The left ventricle loses its ability to relax normally because the muscle has become stiff. This can definitely be the case with hypertrophy of the left ventricle. The heart can't properly fill with blood during the resting period between each beat. So this is what we would call inadequate preload. So preload is the amount of blood that is gated from the right and left atrium into their respective ventricles. And that could be due to a wide range of different reasons. Or there simply isn't enough room in the ventricle. So during that diastolic phase, when the blood is entering into the ventricles, we may see that there is a reduced surface area within the ventricle that can allow a sufficient amount of blood to be there, which then could precipitate your ejection fraction or systolic failure. Right-sided heart failure, which can lead to a few other more complicated situations. Left-sided heart failure is going to be your more critical heart failure, one that's going to carry a much more higher mortality rate than what right-sided heart failure is. Right-sided heart failure is the heart's pumping action moves used blood that returns to the heart through the veins, through the right atrium and into the right ventricle. The right ventricle then pumps the blood back out of the heart into the lungs to be replenished with oxygen. When we look at right-sided or right ventricular failure, this usually occurs as a result of left-sided failure. So always remember that left-sided failure would generally precipitate right-sided failure. When the left ventricle fails, increased fluid pressure in effect transfers back through the lungs, ultimately damaging the heart's right side. When the right side loses its pumping power, blood backs up into the body's veins, and this usually causes swelling or congestion in the legs, or what we would refer to as peripheral edema. Ankles and swelling within the abdomen, such as the GI tract and liver. So what happens is, as your left side starts to fail, the right side continues to pump blood over to the left side. The problem is it can't go anywhere, so that gets pushed all the way back through the pulmonary system and into the right ventricle, and there's just too much blood, so it pulls in the right ventricle. It can't contract properly. It then starts to pull back into the right atrium and eventually ends up back in the circulating body. The problem is, if we don't have blood coming back, we can't send blood out. Congestive heart failure is a type of failure which requires seeking timely medical attention, although sometimes the 2 terms are used interchangeably. As blood flows outside of the heart slows, blood returning to the heart through the vein backs up, causing congestion in the body's tissue. Most often, you will see it as edema in the legs and ankle, but you may see edema in other areas of the body, so thickness in the digits and stuff like that. Sometimes the fluid will collect in the lungs, causing pulmonary edema as well, and if left untreated, will precipitate respiratory distress. As we learned in hypoxia, one of the causes of it could be pulmonary edema because we can't transfuse our oxygen through the alveoli into the systemic circulatory system. Heart failure also affects the kidney's ability to dispose of sodium and water, and this retained water then compounds the buildup of edema in the body. What it looks like when we look at our patients is on the right, you can see the edema build up in their legs. So when you actually push into it, it will hold that shape for a little bit of time. You can see in the top picture, jugular venous distension. So you can see that there is quite a bulging in that vena cava and makes it very obvious that there is pooling occurring back into the venous system of the body. Common symptoms that we'll see when we start to have our patients transition from what could be an ischemic attack to chronic heart failure would be exertional dyspnea or dyspnea at rest, orthopnea, central peripheral cyanosis and changes in the colored pallor, acute pulmonary edema, so listening for those wheezes, crackles, or other gurgling muffled sounds. Check the pain, pressure and palpation, tachycardia, fatigue and weakness due to a reduction in the overall availability of blood and oxygen, nocturia and oliguria, anorexia, weight loss and nausea, exophthalmos and or visible pulsation of the eyes. You can sort of see it when you look around the eyes of the patient, you can see that pulsation. Distension of the neck veins would be a late sign, so would weak, rapid and thready pulses. The riles and the wheezing you could hear early on, potentially depending on how much fluid is there. Increase the intensity of the P2 heart sound, so that secondary heart sound that you do hear. Hepatojugular reflux and the S3 gallop and or pulseless alternates. This is the way that the QRS or the way that the heart beats in a galloping function every 3 steps. The easiest way to explain it. Ascites, hepatomegaly and or anascaria. So just generalized edema. The hepatomegaly is an increase in the size of your liver. You can see this also in the cardiac muscle and a few other muscles within the body that can be stretched and grown based on fluid accumulation or overworking. We can see here with the clinical picture that there's a whole range of different presenting clinical symptoms, but a lot of these are not going to be indicative of an acute myocardial infarction. And that is the S3 gallop, the jugular vein distension, the falling O2 saturations, dyspnea, orthopnea, and crackles and wheezes. These are some of the things that will be prevalent in congestive heart failure as opposed to an infarct that has occurred. The out-of-hospital management is to address the cardiogenic pulmonary edema, which results from an inability of the heart to pump effectively, resulting in accumulation of fluid. The underlying causes of cardiogenic pulmonary edema can include congestive cardiac failure, left ventricular failure post-AMI, which is an important one for us to understand, that if our patient has sustained prolonged ischemia to the heart, we may start to see a profound impact to the ventricle. And if that dysfunction in the ventricle continues to occur, it will then precipitate right-sided failure and cause this high buildup of fluid, hypertension and pericardial tamponade. So we know that the treatment for pulmonary edema is something that we can manage in the pre-hospital setting. So we follow the same or a very similar process to what we did before. DRS ABC, posture according to the patient's condition, oxygen therapy, IPPV is preferred to push the pulmonary edema out of the pulmonary system. Monitor your patient's vital signs, ECG and oxygen saturations. If it is left ventricular failure that you indicate could be the potential cause, posture accordingly, sitting with the legs dependent. Pull that blood away from the legs and bring it back up to the body. External chest squeezes to assist patient ventilation. Cannulate and obtain IV access and treat your arrhythmias depending on what they are, as per protocol, whether that is the internal paramedic protocol or from an organization that you're working for. Provide GTN 5 milligrams sublingually, provided that systolic blood pressure remains above 100, and repeating one time after 5 minutes as required. At an ICP level, you can offer morphine or intranasal fentanyl. What we're going to add in differently here, and because we have quite a significant amount of edema in the body and likely reduced liver functions, kidney functions, we're going to give what's called furosemide, which is a diuretic. So it promotes removing fluid from the body. On diuretics, it is 1 milligram per kilo IVI if they are not on established diuretics. And look, this might be a patient who has chronic pulmonary edema, so they are always on diuretics. So you need to find that out in your patient history. If wheezing is present, do not give nebulized bronchodilators until after the first 2 doses of glycerol trinitrate. We need to vasodilate our patient before we attempt to give bronchodilators. If no IVI access is available, you can look to give furosemide via intramuscular injection. If symptoms persist, a 3rd dose of GTN may be given under protocol and arrange transport to the nearest facility as soon as possible. When we look at differential diagnosis, we need to be mindful of the close association between diagnoses consistent with asthma and pulmonary edema. Look for some key markers such as history of acute or chronic lung disease, history of AF, coronary bypass, or ischemic heart disease. Often a response to precipitant in asthma. So if you are late stage asthma, you may see pulmonary edema. Rapid development of moist crepitations in both lung sounds above bases would favor pulmonary edema. So there's different places in which you will auscultate your patient to determine whether the obstructions or complications are at the base of the lungs, the mid area of the lungs, or the apex of the lungs. Initial phase of pulmonary edema can present as a wheeze. Sympathetic engagement and hypoxemia can be a resultant detection of both asthma and pulmonary edema. Chest pain as opposed to chest tightness. And peripheral pitting edema. These peripheral edema and these sounds that you listen to when you auscultate your patient are going to be your key indications as to potential pulmonary edema secondary to acute coronary syndrome, instigated myocardial ischemia. And that brings us to the end of the lecture. So I'll open it up for questions.